So to introduce this next topic, I have a little bit of a mini case here. 35-year-old man being treated for depression starts a new medication. He takes this as directed and complains to you, the prescribing physician, about quote-unquote not feeling better, despite having been on this drug for 2 weeks. He insists on trying a new medication. You urge him to stay on this medication and tell him it takes time. He asks why. Well, this concept actually plays into a pharmacologic concept called efficacy delay. And this is a rather odd phenomenon where a new drug doesn't work for anywhere from 4 to 6 weeks, in spite of immediate increases in either norepinephrine or serotonin levels. And this really happens to come about because the brain's response to the drug takes time. And so and other ways of describing this can center around the plasticity of the brain, brain dynamics, protein dynamics, the fluidity of the brain, counter adaptation. These are all kind of buzzwords that I don't think you need to define at this point because you're not going to be a psychopharmacologist. But essentially what we're looking at is, in terms of brain biology, persistent low levels of serotonin, which has kind of been identified with patients with depression, are typically associated with a reduction in these serotonin receptors. Typically associated with more serotonin receptors postsynaptically. So let me say that again. Low levels of serotonin systemically is usually corresponded with increased levels of serotonin receptors postsynaptically. And so that kind of makes sense, right? I mean, the body's response is it needs serotonin, it's looking for it, it thinks that the receptor number is insufficient, so let's increase the number of receptors to try to increase the chances of grabbing more serotonin. These patients that have depression and some of these other CNS diseases are typically deficient in these neurotransmitters, or at least deficient in enough concentration of neurotransmitters to produce and maintain normal physiology. And so what do the drugs do? They increase these serotonin levels, and then that corresponds to an increase in neuroprotective peptides and proteins such as BDNF and BCL2, and I know Dr. Bitts talked about those. And essentially these drugs are what I like to call miracle grow or fertilizer for brains, right? And so you see a reduction in these serotonin receptors initially, and then the brain physiology starts to change based on these drugs. And so that change in brain physiology because of these drugs takes some time, and it takes about 4, 6, maybe 7 weeks for these neurological changes to manifest themselves, and so the patients won't feel better. And so this is kind of in contrast to beta blockers, where we can give a beta blocker and within an hour or two we can see changes in blood pressure. If we give esmolol, for example, we can see changes in heart rate almost immediately. Likewise, we can give nitroglycerin for angina or angina, however you want to describe it, and we can alleviate that pain, that chest pain, within 15-20 seconds. So we're kind of used to this immediate outcome from these drugs, and these centrally acting drugs, especially drugs for depression, bipolar disorder, they really take some time to kind of kick in. Okay. Other pharmacodynamic things that I want to talk about include herbal medications. And so St. John's wort, which is a really popular over-the-counter herbal supplement, basically geared towards treating depression and some of these neurological, psychiatric conditions. These drugs actually, or these herbs actually have a major side effect with some of these drugs that we're going to be describing. And so St. John's wort can inhibit the SERT, which is the serotonin reuptake, but it can also inhibit the NET, which is the norepinephrine uptake or reuptake. And the active ingredient in St. John's wort, hypericin, also has demonstrated activity against monoamine oxidase. And so there's a lot of molecular targets of this natural product that mirrors or mimics prescription-based medications, which we're going to be talking about. Moreover, St. John's wort is a well-known CYP3A4 inducer and a potent P-glycoprotein inducer. Okay, and because of its side effect profile, it's got fewer side effects than these drugs up here. You can see these herbal supplements being taken quite liberally by many patients. And so this is what I kind of wanted to focus on. This is why I brought this up. I want to talk for a little bit about P-glycoprotein and CYP3A4. P-glycoprotein is essentially a pump. And what it does is it looks for foreign molecules, or xenobiotics, and pumps them out of the cell. And so in this particular diagram, we're looking at an anti-neoplastic drug or a chemotherapeutic drug. It could be any drug, basically, antibiotic, antiplatelet, beta blocker, chemotherapeutic drug, or in this case, CNS drug. And when these foreign molecules are placed into a cell, this P-glycoprotein pump just actively pumps them out. Now, if you look in the literature, or if you've taken molecular biology courses, P-glycoprotein is known by many names. It's also known as the ATP binding cassette or the ABC transporter. If you're a microbiologist or somebody who studies antibiotics, they're also known as the multiple drug resistant pump. And if you're an oncologist or a cancer researcher like me, you may have just known it as P-glycoprotein or MDR. In any case, any foreign molecule, whether it's a poison or a medication that you're prescribing, can be pumped out. Now, what's interesting is that these pumps are normally made in different tissues. The brain, of course, the brain testes, barrier, the endothelium, and several tissues, as well as the kidney and the liver. A lot of these tissues all have P-glycoprotein. Tumor cells in particular can also turn on P-glycoprotein and make more of it when needed. There's a component to this where these drugs certain drugs and certain molecules can inhibit P-glycoprotein. We'll talk about that phenomenon later, okay? But I want to show you the CYP story because I think this is important. And so this CYP story is important because we're going to have to come back to this concept again and again because it is somewhat confusing and it's really hard to memorize because the story keeps changing depending on the drugs. So let's look at this really kind of simple diagram. This is the effect of an inducer or an inhibitor on the biotransformation of substrates that are administered as prodrugs. Okay, so it's a very specific example, but we're going to go through it. And so here's a prodrug. So obviously this thing does nothing in the body until it becomes activated. And the way it can become activated is through this CYP enzyme system. Okay, now understand that from a drug standpoint, if we're looking at this reaction right here, the CYP enzyme and this prodrug is a substrate, okay, and it gets converted to the active drug. So this is this relationship right here between enzyme and this drug being converted. This is the substrate. Now there's two other players that can come into play over here. We can look at an inhibitor of the CYP enzyme, and we can look at an inducer of the CYP enzyme. Okay, and if we look at them individually, there's one component to each of these stories that you need to be aware of. Okay, so if you supply an inhibitor of this CYP enzyme, okay, the outcome here is that, you know, under normal conditions, we're making an active drug, which is biologically active, of course, and produces therapy. When this CYP enzyme is inhibited, okay, you don't make as much active drug. Okay, and you can tell this is less because I've made it smaller, right? This is the normal amount of drug that's being made. This is a reduced amount of the drug that's being made. And this is at fault because of the inhibitor. Okay? And so the outcome here is going to be too little drug producing very little therapy. In contrast, we have an inducer, okay, which induces the CYP enzyme. And here now we get excess production of the active metabolite. And so instead of making this much active drug, we now make a lot more active drug, and this means excess therapy. Okay? So what we're really describing here is not what happens to the inducer. So the inducer is just the drug that's given with this drug. It's the effect of the substrate, right? So the substrate is the thing that we're producing for therapy. When we give an inhibitor plus a substrate, we get too little therapy. When we give an inducer plus a substrate, we get excess therapy. And of course, the therapy is being relative to the effect of the substrate, which is shown here. Okay, so this is really important. I know this is super confusing, We're going to come back to this several times throughout the year and next year. And you will learn this eventually. I'm not going to make you memorize all these drug-drug interactions. But this story right here, which is shown right here, this is the basis for almost every drug interaction that you're going to encounter in your professional practice. Okay, so it is important, but it's confusing as hell. So we'll try to piece this together. Let's end here because we're running out of time, and we'll pick up on serotonin syndrome in the next slide.